Welcome to the Poisoning Podcast. I'm your host, Erin DeLullo. Please like, review, and share this show with a friend. And today we have a great show with Dr. Stephen Loyd. He was portrayed by Michael Keaton in the Hulu series Dopesick, which is based off of Beth Macy's book, Dopesick. If you haven't read the book or watched the series, you should. Dr. Loyd is an internal and addiction physician who holds a medical degree from East Tennessee State University. He is the chief medical officer of Cedar Recovery in Tennessee. He was the chair of Tennessee's Opioid Abatement Council, and before that, he served as Tennessee's top drug policy expert. Now, he's living in my state of West Virginia, and he is the director of the West Virginia Office of Drug Control Policy. Welcome to the Poisoning Podcast, Dr. Loyd. It is a pleasure to have you join us.
Thanks, Erin. I'm so glad to be here.
So I want to start with some numbers. In 2023, an estimated 54 million people over the age of 12 needed treatment for some type of substance abuse disorder, but less than a quarter of those people received any type of treatment. And that's just heartbreaking to me about what it says about our addiction issues in America right now. So can you sort of give us your viewpoints on our healthcare system?
So the first thing, Erin, I'm a little bit shocked that many people got treatment. So I have to say that caught me off guard. You know, the standard number that I use in my daily work is about 1 in 10 people who need help get it. And it may be a little different, you know, data set or what have you. But when I think about other diseases, because I'm an internist by training, diabetes, hypertension, you know, about 8 to 9 out of 10 people get help. So regardless of what the number is, both you and I know it's really too low. And so my reaction is the same as yours. It's heartbreaking. You know, addiction will assuredly kill you left untreated. And so when I hear those numbers, it's the same reaction every time. I can't believe that that's the United States because our healthcare system doesn't provide access to care for this population at the level it does for other so-called real diseases. And so, you know, it's a challenge, and it's why I work in this field.
It is. And so when you started in medical school, and yes, you were an internist first, did they teach you anything about addiction medicine?
Nothing. You know, and I know you know a little bit about what I do, but, you know, I've traveled the country for, 15 years doing this from, you know, California to Maine to Florida to Texas. I mean, there's no part of the country I haven't talked about this in. And one of the things I always talk about you know, in the lovely state that, you know, you and I get to live in, we don't have the infrastructure from a workforce standpoint to help the people that need help. And, you know, I went to medical school for 4 years and residency 3 years. Addiction medicine was not anything that I even really know existed. And this is really the number one health problem in the United States. And people don't believe that. They say, oh, heart failure, cancer, infectious diseases. And I tell them absolutely not. If you don't believe me, how many people die every year secondary to nicotine addiction? It's the number one preventable cause of death in the world. And so it's the number one problem that we have. And in our state, West Virginia, we're the worst state in the country when it comes to this. And yet on all of medical school and all of residency, we get 0 hours. We get 0 hours on the proper prescribing of controlled substances for acute and chronic pain. We get 0 hours on the recognition of risk factors for and the referral to treatment of people with any kind of substance use disorder, unless you happen to go into a psychiatry residency. And so it's really an indictment of our system. And Erin, I'd like to tell you that, you know, 20 plus years deep into the opioid crisis, that things have changed, but they really haven't changed a whole lot.
Right? There's not a lot of change.
No.
And it makes, so I was reading you're the medical director of Cedar
Recovery.
Cedar Recovery. Thank you. I was going from memory. I didn't have your intro right in front of me.
It's okay.
But you do medically assisted treatment at Cedar Run, correct?
Absolutely. You know, it's the hallmark of what we do. And, the truth is, Erin, when, I graduated medical school in 1999, residency in 2001. And of course, I had my own issues with addiction, which is how I got into this
Yeah.
field. But, if you look at this, medication assisted treatment has about a 70% mortality benefit. And so that means that 70% of the people who wouldn't have died or who would have died don't. And yet we're this deep into it, and we still have to fight for access for MAT, even in West Virginia.
I'm
And
aware.
I know, the session is winding down as we speak right now, and I can't wait till it's over. And there's so many things that happen that would dismantle our system. And in West Virginia, our system is starting to take shape. No work that I've done, work people before me, and I could name
Right.
them, just wonderful work. But it seems like every session we're trying to battle to keep access to where it needs to be because people don't believe in medication, whatever that means. I don't have any clue. I mean, what if I didn't believe in chemotherapy? I don't
Right.
really know how to react to that. And so that part becomes disheartening. But once we get through session now, now we can start talking about how we, further the work that's already been done by those that came before me.
So I haven't spent in my weekly podcast a lot of time on medically assisted treatment. Could you describe a few of the drugs that are used? Just sort
Right.
of the basics
Right.
for us.
Right. Three big ones, right?
Yeah.
So the one that everybody's heard of is methadone, and that's almost a four-letter word, particularly in West Virginia.
Yes, it is.
Buprenorphine, which is a hard word to say, and it's sold under many different trade names, but the one that people recognize is Suboxone. And then last but certainly not least is naltrexone, which is is sold under the trade name of Vivitrol. And so these drugs are markedly different, and all three effective in the population that it works for. So naltrexone is the least controversial of the three, and the reason is it's not an opioid. People say, "Oh, you're going to treat opioid addiction with an opioid. You're switching one drug for another," and so
Mhm.
you really have somebody that doesn't understand the basics of addiction and why treat with medication anyway. Naltrexone is the least controversial of the three because it's not an opioid. It's actually an opioid blocker. So it
Okay.
sits on the receptor that heroin and fentanyl and pain pills attach to, and it blocks the effect of it. Okay. And for the population that it works for, it's a tremendous drug. The next drug that I'll go into a little bit is buprenorphine. Buprenorphine sold under the trade name of Suboxone. It's not as controversial, although it is. It's like a
Mhm.
partial agonist, which means that it's partially like an opioid. And so I describe it to people as, what if you had an alcohol out there like Jack Daniels? And I'm
Mhm.
a Tennessean, so we use Jack Daniels. And it tasted just like Jack Daniels, and it had the same effect as Jack Daniels up to a certain point. And then that stopped, and then you could drink all you want on top of it. It doesn't give you any more effect. And so that's kind of how I think of buprenorphine. It gives you a little bit of effect in the fact that it stimulates the receptor so you don't get sick when you don't have it. But the more of it you take, it doesn't give you any more effect, and there's no euphoria associated with it. And that's really how it works. And then last but not least is methadone. And methadone is a full opioid. It's a full opioid agonist. It's like oxycodone, heroin, fentanyl, only it has a really, really long half-life. So it basically sits on that receptor. It doesn't produce a euphoria or a high in people who are not opioid naive, and it prevents them from using other opioids. And so that's basically how they work. And all three of them are very effective in the population that they work for. And two of the three, buprenorphine, Suboxone, and
Mhm.
methadone, have a mortality benefit, meaning 70% of the people who take them that would have died don't. And that's a good thing, right?
Huge.
People would argue against this. You're actually arguing to let people die. And I can't understand that. And a lot of times, it's going to be, and I'm sorry, it's going to be folks from the faith-based community or who have this very strong faith background. And I'm from the faith-based community, and I got into recovery faith-based. What I realized, though, with time was that I had every social determinant of health going in my favor. I'm a doctor. I got a six-figure income. I'm not living with somebody who's using. I mean, come on, Erin.
Yeah.
And medication actually helps those folks to not die. And so if I can keep them alive, right, and I can quell their cravings, because that's why people relapse. It's why me and you relapse 3 times a
Yeah.
day, right, with food. We have cravings, we're
Oh,
driven to eat, so we eat. So it's the same reward pathways that the drugs we're talking about work on. And so if I can keep them alive, right, and keep them away from the bad stuff. Now we can start to help them with those underlying drivers of addiction, which for the most time are trauma, physical, sexual, emotional abuse, and underlying mental health issues that are untreated. So it's really as simple as that. And, I could describe that in 3 minutes.
No, I agree with you. And I almost think when we go back to OxyContin, which you were harmed by, there were bad actors
Hmm.
around Oxy, whether
Sure.
it be the Sacklers, right,
Hmm.
that were lying about that it wasn't addictive,
Right.
or pill mill doctors who were just constantly right over prescribing. But we still can prescribe that drug, even though it's more limited. The drug is not off the market today, even
Right.
though there were bad actors involved. And I have no doubt that there may be some bad actors in some clinic settings with methadone, or patients misusing or taking it out and selling it. But does that mean no one else should have availability to it? That's just my sort of thinking about what you're saying. That's how I think about these two medicines.
So Aaron, what I would tell you is you have wonderful common sense. Yes. Yes. I mean, I don't know how to, that's an easy answer. Uh, the truth is that drugs like OxyContin don't need to be taken off the market.
Right.
They have a clinical benefit for folks with intractable chronic pain that can't be addressed by other modalities. Now that's a small number compared to the number they shot for, which was way overblown, obviously.
Yeah.
But those drugs don't need to be taken off the market. And when you describe it the way you described it, it's exactly right. We had bad actors in that place, but that medication has a benefit for a segment of our population that cannot find relief any other way. Chronic cancer patients, end of life, metastatic cancer, particularly that
Mhm.
involves bone, that's really, painful. Those medications are life-saving and life-altering for those folks, and they do not need to be taken off the market. What the Sacklers did was widen the scope that you expose people to these potentially harmful drugs, and so the risk actually was not outweighed by the benefit, and they did it intentionally. And so, in my opinion, they're sociopaths. They don't have a conscience, and
Yeah.
there's not a lot of those. And most sociopaths wind up in prison. And I could tell you, I think the Sacklers should wind up in prison. They
Amen.
won't, but they should. And
Amen.
so, yeah, your line of thinking, I think, is wonderful, and it's spot on. It's common sense, and it's not affected by the dollar. The problem is when the dollar gets involved, and then that starts to shades people's thinking.
So I'm going to ask, we're going to get all the hard work done in the beginning. So there's another drug I would say that's in research phase that there's a crate, maybe uh, definitely has some following, but I don't know that it has proof. So
Hmm.
the people are like, why would you treat an addict with another drug? Ibogaine.
Hmm.
And I know there's it caught on in Kentucky for a while when the commission was really looking, the opioid abatement commission there was looking to spend a lot of money on it, but then they pulled back, and now there's a bill here in West Virginia on it.
Hmm.
So have you seen any research or proof in your work that Ibogaine is working with opioid use
Oh,
disorder?
sure. Yeah, yeah. Not only Ibogaine, and there's a lot of them. The psychedelics, right? If you grew up in West Virginia,
Mhm.
mushrooms can't shock you, right?
Right.
Psilocybin is actually the correct name for mushrooms, or even LSD. And so there's anecdotal and some research evidence that these drugs are effective in helping people with substance use disorder. The problem becomes is when you bypass the pathway, to approval for an
Mhm.
indication. It's like the public deciding whether or not somebody can use this medication or not. That doesn't need to be the way it is. The public doesn't understand a lot of things. It's like you just said. I can't understand treating opioid addiction with an opioid. Well, this one doesn't kill you. How about that? Let's
Right.
start there. And these drugs have been researched. They've gone through the FDA process. We know the dose of medication. We know the risk and benefits. We know the half-life. We know the pharmacokinetics of it, and we can educate people on the proper use of it in a recovery program. My problem with drugs like Ibogaine, and we can throw some other ones out there that are even
Yeah.
more controversial than that, like kratom, right? And I don't have any doubt that there are people that are helped by this medication, but when they're marketed in head shops, that becomes an issue. And I don't need a head shop. I don't know what you all call them. Back in my day, we called them head shops, but now vape shops, they sell,
Yeah.
Delta 8, Delta 10, cannabis products. When that's your marketing strategy, then I got to question that. These drugs need to go through, in my opinion, need to go through the FDA process, although there's holes in that, and I get that. But they need to go through the process like everything else. And then, then we know the correct way to use them, who they're indicated for, what the dosage is, and what their limitations are, because none of them are perfect. And so I think we need to have access to every tool possible, including the psychedelics, if they've gone through that process and we understand their role and how to use them. But when you start shortcutting that, Erin, then I think, first of all, you stigmatize it, because I don't know about you, but I don't feel very comfortable buying my pharmaceuticals in a place that also sells, bongs. Right? And that's just me. And right. And
I don't even want my ointment, Neosporin for a cut in a place that
of
sells
course.
bongs. No.
And I think we have to talk honestly about that, because we get that marketed to us. And so I'm a physician, I'm a clinician, I'm a scientist as well. And if I'm going to use medical cannabis, well, I need to know what the indication is and what the dosage is, and then what are the risks and what are the benefits, instead of somebody just saying, oh, we need to have medical marijuana, and they sell it in a vape shop with a marijuana leaf out front that looks like the t-shirts we wore in high school. I mean, that doesn't instill a lot of confidence in me in the process. And so I'm not against any of it, but I do think it needs to be studied and regulated, because if it's not, then we wind up with the same thing that we've gotten before. So Ibogaine is one of those. I've seen people that have responded to treatment with Ibogaine.
Okay.
And, my problem is I don't know what the number needed to treat to where you get a response is, right? I don't know what that is. I don't know what the pharmacokinetics of it are. I don't know what the dosage is. I don't know for how long a period of time, because it hasn't been reviewed by the process that we as clinicians and doctors are familiar with.
No, I agree. We see this nationwide, not just here in West Virginia, not in your home state of Tennessee, but it's a for-profit marketing system, and we've let our culture say marijuana is no big deal.
Right.
But we have more and more people using it daily, not for medical reasons. I was actually just talking to a work colleague this past week about my podcast and addiction, and she said, Erin, my sister, the first thing she does when she wakes up, and this is like a 30-plus-year-old professional woman, has to smoke pot or take some form of marijuana when she wakes up.
Right.
Wow. But, and I've said, well, what is she now spending on this? Like, not only is, there's a financial concern, a health concern, but we have just let our culture accept that it's okay. And people are using it younger and younger. So what are these long-term effects? I don't even think we know yet.
So it's so interesting, because we actually had a bill in our legislature in this session that I testified on in front of our Senate, I think, Judiciary Committee. And here's the truth, Erin. If you're 60 years old, 70 years old, and you like smoking weed at night and taking a gummy to sleep, I could care less. I mean,
Sure.
seriously, I can. I don't care. When you start marketing it to kids, then I've got an issue. And the real issue here is, and I've got a wonderful friend back in Tennessee at Vanderbilt University named Kristen Gilliland, who's a PhD, who lost her son to a cannabis product. To me, she's the go-to, and she has taught me about the developing brain and what happens to developing brain is exposed to cannabis. And I told you and Matt, both of you guys look young, and you are, but you're past 23 and 25.
Yeah.
And at that point, our brains, if you're 23 and 25, 23 is a female, 25 if you're a male, these areas of your brain that are concerned are pretty much developed. When you start talking about exposing adolescents and teenagers to these products, you're talking about affecting a developing brain. And you have to balance the economic gains from places that are doing business and the marketing strategies they have against what it's going to cost you in the long term with regards to brain development and further SUD issues with this population. And it's what I told the legislature. I mean, you're sitting in those chairs. You're the ones that have to make that decisions. Because you can't convince me that you're not marketing it to kids when it comes in the form of gummy worms and chocolate bars. And you can tell me all you want, and you can pay your lobbyist, great big money from other places that are wearing really nice suits to come in here and tell us all the things you're doing to protect that from happening. Your business model is to make people to get people to use this repeatedly. That is your business model. And for the longer period of time they do that, the more money you're going to make. So I'm going to be really, really skeptical of you and your high priced suits telling me this, because the truth is that it does get into kids' hands, and these kids wind up becoming lifelong users, which also pads your pockets. And so we have to be honest about that. And I'm not going to be any other way. And on the backside of it is, when you're developed and you're an adult and, you want to use these products, as long as you don't get behind the car and drive or hurt somebody, I could care less. But I think when we're talking about kids, we have to be really, really careful with that.
Yeah, and the states have even a hard time keeping up with what shops. They're now having it's like, oh, sometimes people think, oh, new tax revenue, right? But they forget that there's just more in store. And I know in Oklahoma, they will just have stores pop up, and the consumer does not know what store is legitimate and what store isn't.
They don't. No, you don't. And I wished I had this data for our lovely state, my home state. I do have the data for, and the most popular, the most what do I want to say, the most locations of a retail service in Tennessee is Dollar General and Starbucks, right? But if you throw in places that sell vape products, THC, Delta 8, Delta 10, there's 3 times more of those. There's about 7,000 of them in the state. And that's just mind-boggling. And so, as I learned West Virginia and I'm all over the state, right? And in West Virginia, everybody says it's a small state. You think it's small, drive across it.
Yeah. Takes a long time. Doesn't it?
Drive from Weirton to Harper's Ferry and tell me how small it is. And, but I pay attention when I'm traveling the state. And, how many of these places do I see? And it's really incredible. And I think we have to ask ourselves that question. West Virginia has the second best climate for growing cannabis in the United States, only behind California. So I'm sure that we're going to be a target for the cannabis industry. And, we're going to have hard questions to ask. And some of those are going to be economic, right? And we know that our state needs economic opportunities for our citizens. We all know that. But what are we willing to do to make that happen? And that's where I get scared, Erin.
Yeah, I'm very cautious about expanding into marijuana. I mean, medical is one thing, but legalized recreational, I have yet to see the benefits.
Yeah.
That's just when it becomes, I am not, I don't believe in knocking down doors. If someone has something in their home, I am a freedom believer that way. But when you look at society, right, and then you look at, okay, we already have 1 in 7, 1 in 8 babies born with NAS. We have a high population of foster children in the system for our population. I'm sort of thinking, do we need to make these drugs more accessible to these children? And to me, when you put them in those shops, it becomes accessible to everyone, even children. And I go, I don't think that's good for us right now. It's Erin DeLullo's personal opinion.
Well, again, I mean, it's also common sense, and I mean, and I think that we do have to ask ourselves those questions. And our state is really unbelievable, right? I mean, and I'm still not used to living here. And there'll be times I'll be driving up the interstate 77, 64, 79, whichever one I'm on, and I'll turn a curve and then I'll look out and I'm like, oh my gosh, and I'll pull off the road, and look at it, because it's such an amazing place. But we also have more than our fair share of societal ills. And, more than what's the statistic? More than 40% of the kids in West Virginia are being raised by somebody other than their parent. I mean, it's an ungodly number. And I know the people who are trying to help those kids, and I can tell you they are some of the hardest working, most kind and compassionate people I've ever met in my life. And I've only been here 7 months. And we have to ask ourselves, how do we get ourselves out of this? Is this going to help us in our goal, or is it going to hurt us? And I'm going to come down in your court. I think it hurts us. And but we have to ask hard questions, and then from an economic standpoint, and I'm not the governor, and I'm not Governor Morrissey or anybody else, but what are the things that we can do to build our state up and make it attractive economically so that people can have upward economic mobility, which is what we're all after, because our state is ungodly beautiful. But our resources have been, have been compromised for years. And we all know that. It's not a secret. And I grew up in Appalachia. It wasn't West Virginia, it's Northeast Tennessee, but Appalachia's Appalachia. And so how do we start to balance these things? And I think, Erin, your questions you're asking are really good.
Thank you. Well, do you practice still daily, or
not daily, but no,
not daily? Or how often are you practicing addiction medicine right now?
It's I have some kind of interaction with it on a weekly basis for sure. Matter of fact, I was a little delayed with you, and I'm sorry for you and Matt. That was a little delayed, but I was actually participating in in an intervention to try to get somebody help, who couldn't see it for themselves. So, and I do this, I'm boots on the ground in West Virginia. I've been so impressed with our criminal justice system, particularly DCR, Department of Correction and Rehabilitation, although the Trump administration stole our guy, right? So they took Billy Marshall, who I think is the most competent and best person that I've ever met within our carceral facilities, any state I've ever worked in. So the Trump administration tapped him yesterday to lead the Bureau of Prisons for the United States. And for me, I'm heartbroken because I'm selfish and I want Billy Marshall in West Virginia. But it also gives me confidence of where, the people make those decisions because they got the right guy. But this has to be a focus for us in our carceral facilities, our jails and prisons across the state, of being able to address this in there, because there's so many people that are behind bars, and they're behind bars for this reason.
Oh, yes. I think it very much contributes to our prison population, and it's big resource drain. The opioid.
I've been in there, when Billy's one of the first people that I got to know in West Virginia when I first came. He and a guy named Jack Lukert at the Fusion Center in Charleston. These are law enforcement guys. And when I saw their kindness and compassion around this issue and the things that they were willing to do within their facilities to try to help people, I mean, it's amazing. So I still work very closely in this, Erin. I've been in several of our carceral facilities in West Virginia. The biggest one's St. Mary's in Pleasants County. And I tell you, I just love the things I see with trying to help people, build a life, because 95% of the people behind bars are going to walk the street again. I mean, that's a fact. And do we want them walking the street sober, treated, or otherwise? Because they are. And so I think we need to take a look at that in investment of our dollars, because I think our dollars are well spent there.
I'm going to try to find this study and put it in my newsletter that will go along with this podcast. But there was a recent JAMA study, Journal of American Medicine. Matt is always reminding me, explain things, stop using acronyms, Erin. That when someone is released back into society from prison, if you give them naloxone when they are released, it has brought down the death rate, because it's so hard, that transition period back into society. So I hope we're doing that. I don't know if we're doing that here in West Virginia.
We are.
But I hope we are. Oh, good. Great.
No. Yeah, so it is. It's the population most at risk to die of an acute overdose. And so if you look at, and this is across the country, if you look at people who are incarcerated, no matter how long they've been in the 2 to 4 weeks after they get out, they're 40 times more likely to die of a drug overdose than an age-matched individual in the community. 40 times.
Wow.
And so that is definitely our target population. And we have I'm telling you, you can't believe how West Virginia is blessed with what I consider to be Mount Rushmore type people. And we have people working in this field with regards to harm reduction and availability of overdose reversal drugs that are amazing, particularly at UC, the University of Charleston. And so when folks are leaving our carceral facilities, they leave there with naloxone. They leave there with overdose reversal drugs. And, but you don't have that happening without people like Billy Marshall, right? Somebody who is over that. Billy's over every jail and prison in the state of West Virginia. And if you've got somebody in there who believes, all right, I'm tough love and this and that, and, more harsh penalties will fix this, then you don't have somebody that's willing to look at what the evidence shows us, that if we get Narcan in these folks' hands, we save lives. That's actually true. And if you look at the overdose numbers in the state of West Virginia right now, for the first time in probably 30 years, we're headed in the right direction, and by big margins. Now, the whole country is going down, but we're going down faster. And I would like to tell you it's because I showed up on the scene.
Yeah.
And that is
7
not
months
true.
ago, you checked that box.
That is not true, right? All of this work was done by people before me, Bob Hansen, Matt Christensen, the folks we have around our state doing this work. And so our overdose numbers, December 24 over 23, deaths down more than 40%. Emergency department visits down more than 40%. So these things are really amazing, and the rest of the country is down too, but we are significantly down faster. And so our system of care and the folks in the state have worked on it for such a long time, including in where you are in the Eastern Panhandle. It's just amazing what's happening. But really, I'm gonna point to DCR and tell you that without DCR being involved, that these numbers don't look like they do.
No, and I think, from my work, I believe that naloxone plays a big role in this, that it's out there more. It's doesn't have the stigma that it used to. And I was actually saving my naloxone comments for the end. I usually do it at the end of the show, but we're getting into it now. So I think it plays a big role, right? But I still find people in my journey in this project, still find people in decision-making space in drug policy who don't even have naloxone. And I don't want to publicly shame anybody, but I'm sure I'll get a few texts when this episode drops. They're like, are you that's talking about me? I've had to hand out boxes. It is not, in my opinion, sure, there's a box at the emergency room where sort of like a vending machine box, or at the health department, but it's still not everywhere it needs to be. And most parents, or even where I go to church, they don't have it. I think it's so affordable, gives somebody a second chance. I mean, what drug, if you're, what's it, $29, $26 for generic, and it can bring someone back to life? I just think we need it more places. That anybody who listens to the show will know that, it's not hard. I keep one in my purse. You just don't know when you have the chance to give someone a second chance.
In West Virginia, it's basically free. So
I know.
Yeah.
I know, but I feel like it should be handed out at churches, to the parents in the school line. It's not this expensive drug that has to be refrigerated, but major decision makers didn't have it. I've corrected them when they come in contact with me. Even when I interview someone from, who writes on health policy in another state, they don't have. I'm like, okay, you're sending me your address, and I'm going to ship you some naloxone.
Well, let me tell you this: if they're writing health policy around this issue and it's not on their radar, they don't need to be in that position. And
I mean, it's just general health policy, and of course they think everyone thinks it won't happen to them, or they won't be around someone that.
So I got a quick story for you on that one.
You're okay with it? Story.
So Raul Gupta, West Virginia, right, was the drug czar of the United States. And in one of his first years in office, he had National Recovery Day at the White House. I got to go. And he had a panel on the stage, and there were famous people, 3 famous people: Chris Carter, wide receiver in the NFL, Ariana Huffington of the Huffington
Yeah.
Post,
Oh,
right? I mean,
sure.
some really significant folks in recovery. And then he had this mayor from Minnesota, some small town. And I sat there in my judgmental self and going, what the heck's that mayor from Minnesota doing up there? Until he spoke. And he was a
Oh,
mayor of a small town in Minnesota, and his police force and his anti-drug coalition came to him and said, hey, what do you think about arming our officers with Narcan, overdose reversal drugs? And he basically kiboshed it. He said, I
no.
don't think we need that, and this and that. He said he was working at his house one day, came home early from work, and sheriff's deputies showed up at his house and informed him that his daughter had died of a heroin overdose.
Mm.
And he quickly became the most important person on that stage, because I'll never forget that. He was the guy that basically prevented it from happening. And then his daughter is the one that died. So when I see people, from a policy making decision standpoint and talk about overdose reversal drugs and let's limit it here and limit it there, let me ask you this. Do you want somebody to have it on them when your kid overdoses?
Amen. Yes.
And then I get other people say, well, how many chances do you get? I don't know. How many times do you want me to pull your kid back? All right.
Well, yeah. Wow.
Mm-hmm. And you think it can't happen to you. And we've got some folks like that. And we've got some folks who, if I could get down to them and put them on a lie detector test, that they would prefer that these people just die. And I see it, I know it. And so, my question to you is,
Yeah.
first of all, I think we could all agree that if the Bible Belt has a buckle, that it's somewhere in the boundaries of the state of West Virginia.
Mm.
And, it's not even biblical. Right, that it couldn't be further from biblical. And then the other thing is, what about your kid? How many chances do we give your kid? And my opinion about that is, how many do they need? Right, I don't have a cutoff, because I certainly want to cut off for my two children and now my grandchild. And I think we have to look at that, Erin. And I think it's too many times, let's think about the person who connected me and you.
Yeah. Oh,
Right,
Ed.
that's right.
Oh,
Now,
God
Ed,
bless Ed.
yeah, look at how Ed has fought since this happened in his family, how Ed has fought this issue. And I see people like Ed. Ed sends me an email, said, hey, Steve, you need to meet my friend Erin. I'm gonna
Yeah.
reach you, right?
Oh,
Because
he's
I
wonderful.
respect Ed and the work that he's done. Aaron, this stuff needs to be everywhere. In West Virginia, we've got Sue and Joe Murphy, who came up with this thing called One Box, right? It's like an
Mm-hmm.
AED for
Mm-hmm.
Narcan. You don't need a training. You need to be able to open the box and just listen, right?
Yeah.
It's genius. And we've got places in West Virginia that we can't get One Box in. Are you kidding me?
They won't take it.
Right. We'll
Yeah.
take it. It should be in every school in the state of West Virginia, preschool, church, rest
Yep.
areas. All right, nobody travels the state more than I do. All right, I've been in every rest area in the state of West Virginia. It should be in every rest area. It should be in every hotel room. We got a Gideon Bible in every one. We need Narcan in every
Yeah.
hotel room. And if you want to say, well, we don't need the Marriott or the JW, well, we got some ones that we can put in them, and I'll tell you where they are. And so they need to be everywhere. You're exactly right.
Yeah. It's just been one of the biggest eye openers
Mm-hmm.
to me. So when you were practicing more daily, and did you accept Medicare and Medicaid patients
Oh, heck
when
yeah.
you're
Those are the targets. Yeah.
right? That's
Yeah.
so, how are you viewing the upcoming potential cuts? I mean,
Scared to
it's
death. Scared to death.
scared to death.
Scared to
Yeah.
death. And I've been in recovery for almost 21 years. My life is unrecognizable. Um,
Mm,
there are things I can control and things I can't control, and I never was comfortable with that. I am now. Very few things rattle me. The practices that I started back in Tennessee, we never turned anybody away. We
yeah.
were the biggest SOAR, state opioid response provider in
Yeah.
the state. People used to ask me how I get patients on the SOAR grant. And I said, well, I get on the radio on Friday afternoon and say, hey, if you don't have any money and you're addicted to opioids, call me. Wasn't too hard. And so we spent our SOAR money like that. So we've never turned anybody away. And so when you start talking about cuts in Medicaid, what's that going to cost you? one of the things I want to do is I want to show the cost of not doing something, right? There's a cost of doing something. There's a return on investment for that, and either positive or negative. What's the cost of not doing it? And so when we start talking about Medicaid cuts, I get really nervous. It's the one thing that does worry me, because this is our most vulnerable population. In West Virginia, it is our population that is most at risk for this. Well, what do we do when we cut off care to those folks? Is it okay to let them die?
Yeah.
Because that is what will happen. This is predictable.
Yeah, I think we're making such great progress in the numbers in this crisis. And then I think people just think, well, we've got to shrink a budget. But they don't, I think our numbers can go right back up
They
for
can.
overdose and use very easily. And it's
very
just something I'm tracking, and I'm very, with the nonprofit that I'm involved in, we gave out Naloxone via a SAMHSA grant last year, and that's not going to exist moving forward. So,
Well, I think we had legislation, I'm not sure it wound up, that would put a tax on
yes. Oh, I saw that too. Yes, I saw that. Was it tax on test strips and Naloxone? Yeah. Yeah.
And
well,
so
I mean, and maybe it's
I want
from
to
my
address that.
background in politics. I repeat a lot of talking points because you're a good politician when you repeat your talking points, because that means they'll stick in people's minds. I purchased Naloxone just as an experiment at the CVS here in Jefferson County. It was an ordeal. First, did I have a prescription? Then I explained to him I didn't need it. Just nice people who weren't informed. My box cost $77, which no one is going to pay, and it is is not even close to what it's manufactured for or what the state can get it for. And then if you put a tax on top of that, what's it going to be?
So here's the issue with that, Erin, and this drives me every single day of my life. The rationale for putting a tax on these things is that we wouldn't need them if you weren't using, so therefore you need to pay for it. So let's take another disease that is behavioral, that has supplies, and that's type 2 diabetes. I'm an internist.
Yeah.
I'm an internist. I've practiced internal medicine. I treat diabetes, hypertension, strokes, heart attacks, ICUs, medical step-down units. That's what I do for a living. And I can tell you that type 2 diabetes, which is far and away the most, not type 1, type 2, far and away the most common reasons people not eating right and not exercising, that is behavioral. So by that same rationale, we need to have a bill come before our legislature that's going to tax insulin, syringes, and any kind of diabetic supplies, because if these people would watch what they would eat and exercise, we wouldn't be having to pay this money. Now, are you willing to do that? And if you're not willing to do that, then you're actually violating the Americans with Disabilities Act by discriminating against somebody with addiction. And it's not mean. I don't want to fight you. But I want you to look at this. And the only way you can do stuff like that is you look at addiction as a moral failure. And if you do that, then I really can't help you. The first doctor in the United States that described addiction as a disease of the brain was actually Benjamin Rush. And he only did that in 1774, which was 2 years before the Declaration of Independence. So this is not a new concept.
It's not, but you're right. I mean, diabetes is probably costing our state a lot of money too. Yeah. It runs in my family, and I have seen family members shoot the insulin, but then go, eat Krispy Kreme and Dunkin' Donuts and everything else. And
well, you're going to love
I fight
this.
it. I don't want to be listen, it's hard to fight it. Sure, I do have sugar, no doubt. But my goal is not to be shooting it every,
of course,
to survive.
You're going to love this. Before I came to West Virginia, I did not know what a pepperoni roll was. No clue. Right? I'm from Tennessee.
You mean it's not a daily part of your diet?
It's not. It is the state food of West Virginia, right? That and Sasquatch, right? I mean, that's the deal. And I had no idea. And when I ate a pepperoni roll, I see why, because I love them. But I mean, my gosh, it's carb overload, Right.
carb, it's
Right.
processed,
Right.
cured meats.
Yeah. All
There's
processed. I'm not.
probably sugar in the dough. I bet you it's not even just straight flour. I bet a lot of people
Yeah.
lightly sweeten their
Of
dough.
course. Now I love it, right?
Yeah.
And I don't want the people listening to this podcast to say, "Hey, our drug czar was on a podcast and he was
No,
advocating to tax insulin."
no, no.
So I'm not. That's not what I'm
It's an
saying.
example of, it's a comparison
Yes.
for viewpoints.
Yes.
No, I agree. I do not want to tax insulin either, but people need to see it in the same way. And we just have this stigma around drugs still. And I think illicit drugs are bad. And we should think of illicit drugs as bad. We do not need to think about the people who take them as bad. It's
We
totally different.
we had recovery day at the Capitol this session, and
Hmm.
you're only allowed 300. We had all 300 of ours there, and moms with children and smiling, happy faces,
Mm.
and probably a lot of people with criminal backgrounds that you wouldn't think would be smiling. And we got together on the House floor and took a picture. And we were all down there and up in the gallery. They were having school visitation day to the Capitol, which our Capitol is beautiful.
It is. It's
And
gorgeous.
it's incredible. Every time I walk in there, I'm in awe of it. And they were taking our picture, and all of us down there with our past and smiling and in recovery, and we survived. And I looked up at those kids all the way around the cat. I mean, packed.
Mm.
And I wondered how many of them were going to homes after that day that were riddled with the things that nearly took our lives. And it made a huge impact on me as we were all, because we deserve an opportunity at recovery. And those people that want to let these folks die, I want to take a picture. I do have it. I want to
Yeah.
hold it up and say, okay, which one of these should we have let die? I mean, pick them out. And
I
then those,
Do you
you
want to
want to
start
say,
a church tour and
yeah,
do this?
sure, of course.
I can help get you some bookings. I think that needs to be heard.
Yeah.
So, one of the last serious questions I'm going to ask you is about fentanyl. There, do you believe that people can overdose from touching it or vaping it? There's so much, I would say, different viewpoints on it. I've had a guest on who actually an emergency room doctor from Arkansas who said she revived. It took several Narcans to revive a patient who had vaped a supposed marijuana product, but it was laced. Do you have any experience with this,
I
Dr.
have a
Loyd?
ton of experience with it. If you ingest it by any
Mhm.
method, vaping, snorting, eating, it can for sure kill you. And have I seen marijuana vapes adulterated with fentanyl?
Mhm.
Yeah. Matter of fact, we had a school back in my home state where I think 6 or 7 kids overdosed. They didn't die
Yeah.
from a adulterated vape pen. So yeah, that's for sure possible. The big one comes with, oh, I just touched it and I overdosed. No, you
Mhm.
didn't. You didn't.
Okay.
Okay. I'm sorry, but you didn't. Now, if you inhaled it, yes. But if you've got a thing of fentanyl here, I'll ram my arm in it. Okay. And I get it, right? I mean, I
Yeah.
get it. We had we had a tourist come through Nashville, and had seen this on TV that we had this big problem in Tennessee with this, and they had touched a dollar bill at a gas station, and they went down in a panic and overdosed, and they came and the news called me about it and said, Steve, is this possible? And they'd already reported that this person had overdosed from touching a dollar bill, and I said, no, they didn't overdose from touching a dollar bill. Okay, it didn't
Yeah.
happen. And sure enough, when this person, now the news didn't report this part, but when they drug screened him after they got him to the hospital, there was nothing in her system. Okay, and that's paranoia, and that feeds this. Now we have to be very careful because we put our first responders in situations, and we don't want to make it dangerous. And I'm not
Right.
downplaying that at all. And I have a ton of buddies that are cops and everything else in the world, and I would never want them to be at risk. But just touching it, you're not going to overdose. It has no port of entry.
True.
Right. And I guess if you mixed it with something like DMSO that allows things to go through your skin like the patch did, then that would be possible. But That's paranoia, and that's stigmatizing. Now, if you ingest it in a vape pen or any other way, oh, absolutely. And I believe what the ER doctor said with the amount of overdose reversal drug that it took to bring him back, because fentanyl is anywhere from 100 to 10,000 times more powerful than morphine, depending on the analog. So yeah, I believe that's for sure true.
And we don't even know if it's normal fentanyl, carfentanil, all these
You
other
don't.
types
No.
that are just out there.
Right.
Well, we're
And
coming up on time. Let's end positively. You
okay.
speak about hope and recovery a lot. How do you help patients when they're at their lowest think of hope?
And it's sharing experience, strength, and hope with others. It's my main qualification to be an addiction medicine doctor. It doesn't even have anything to do with the MD degree I have on the wall. It has
Hmm.
everything to do with my own experience, strength, and hope. And that's what I bring to the table. And I get more credit than I deserve because I have MD after my name. But there's millions of people just like me out there. And then when you work in our state, I really am in awe of our sense of community. I'm not from here,
Yeah.
and the sense of community in this state is really unbelievable. I went down to a county that my friend Chad Barker is the sheriff of, and in the coal fields, and thought I was going to see Chad, and when I got there, half the town was there.
Hmm.
They care about this, and they care about each other, and I think that's our biggest asset in West Virginia. And then I've got a Mount Rushmore of women, and there's three of them: Rachel Thaxton, Emily Burkhead, and Haley Walker. These ladies lead programs in West Virginia that help people with social determinants of health, housing, and jobs and hope. And they really need to be on Mount Rushmore, in my opinion, with the work they do of helping hurting West Virginians find a life. All three of them are in recovery. All three of them have lived experience, and all three of them share their own experience, strength, and hope. And when we've got people like this working in our state with the West Virginia First Foundation and Jonathan Board and Matt Harvey, I like our chances.
Yeah.
I like our chances.
Me too. Well, thank you for joining the Poisoning Podcast, Dr. Loyd.
My pleasure. Thank you for having me.